Hello, everyone. Welcome. Excuse us for the technical problems we had in the last couple of minutes, but thankfully all are sorted out. Today's webinar is about to start now, and thank you for waiting. The views expressed in the presentations made at European Society of Gynecology webinars are those of the speakers and not necessarily of the ESG. Presentations of any information regarding any specific opinion, commercial product or practice does not constitute an endorsement of the speakers or third parties' views, products, or services. And as you would see at the bottom, there is a Q&A button there, and you can just forward your questions during the webinar. It's my pleasure to welcome two distinguished speakers from Paris, Professor Dabi Yohann and Professor Nathalie Chabbert-Buffet. I hope I pronounced it correctly. Professor Dabi Yohann is an associate professor of gynecology and obstetrics and a consultant gynecological surgeon at Hôpital Tenon in Paris. He practices with the Expert Center for Endometriosis. He is widely recognized for his expertise in the surgical management of endometriosis and gynecological cancers. Dr. Dabi has extensive experience in minimally invasive and low-impact surgery, including advanced laparoscopy and robotic surgery, with particular interest in innovations aimed at reducing post-operative pain and improving recovery. He is the author of over 100 peer-reviewed scientific publications in the fields of endometriosis, gynecologic oncology, fertility, and is a frequent speaker at national and international medical conferences. So it's our pleasure to welcome him today. Professor Nathalie Chabbert-Buffet will deliver the second talk today. She is a professor of endocrinology and reproductive medicine at Sorbonne University and a senior physician at Hôpital Tenon in Paris. She is an INSERM researcher and director of research at the UMR S938 Saint Antoine Research Center. Her clinical scientific work focuses on women's health with particular expertise in endometriosis and infertility. Professor Chabbert-Buffet coordinates the Saint Arisk network and leads the endocrinology unit and family planning center at Hôpital Tenon. She is actively involved in medical education and the development of national clinical guidelines and authored over 213 peer-reviewed scientific publications. So after introducing them to you, the first talk will be given by Professor Yohann, and he will discuss conservative surgery in reproductive age women with pelvic tumors. The screen is yours, my friend.
Well, thank you for this introduction. I'm very happy to be with you today. So let me share my screen. Okay, so now you should be able to see it. Okay, is it good?
Excellent. Yeah, excellent.
Excellent. So today I'm going to talk to you about the conservative surgery in patients with pelvic tumors. And the first question is, what do we mean by reproductive age? In all guidelines, you realize that it's quite implicit, nothing, no specific age criteria to define being able to conceive. And the recommendations, I think, voluntarily entertain this implicit evaluation to be left to the clinician. And it's important that when patient is diagnosed with pelvic tumor, a joint evaluation is by a multidisciplinary team but most of all, that includes gynecologic oncologists, fertility specialists, and of course, radiologists. To date, we have to understand that there is no specific literature as to refer for the potential to conceive in this patient. So we usually use the same criteria as in patients without pelvic tumors, but one cannot say if it's appropriate or not. So there is anti-Mullerian hormone, the antral follicle count, the FSH level, and all the other patient's characteristics. But it's to know that there is no data to precise if it's appropriate or not in this specific population. And this patient with diminished ovarian reserve might still benefit from fertility sparing surgery because sometimes they can conceive either through fertility treatments or through oocyte donors. So let me first talk about endometrial cancer, and I rely on this on the European guidelines for the fertility sparing treatment. So just to remind you of the 2023 FIGO classification, and most of all, we are going to talk about the early stage, which represent most of the cases, specifically in this younger population, and mostly in the 1A stage. So patients eligible, that's the first thing to talk about conservative surgery. They are those with stage 1A and grade 1 tumors of endometrioid type. Patients with grade 2 tumors, still stage 1A, can sometimes benefit from conservative surgery, but the guidelines are pretty clear that patients with stage 1A2 endometrioid tumors are not suitable for conservative treatment. In this patient, expert second reviewing of the pathological specimen is recommended, as well as molecular classification assessment, even if so far the molecular classification has not proved a benefit to elect the patients that will respond well to hormonal therapy, as we'll see after. But it's important to collect this data to help us in the future maybe identify the most suitable patient for these conservative treatments. Another point is that when you establish the diagnostic, it should be obviously based on reliable histopathology, and it should be obtained through hysteroscopic guided endometrial biopsy, which is superior to just a blind biopsy using a cornea pipette, for example. Just a point on patients with Lynch syndrome. Well, they are also sometimes suitable for conservative treatment, but it should really be discussed on a case-by-case basis, and should always be informed about the higher risk of persistence of recurrence as compared with other patients. So it's not a no-go for them, but you really have to discuss with the patient and in multidisciplinary committee, especially in these cases. So when you want to tell the patients about conservative treatment, I think it's important to tell them about the chances of pregnancy and live birth in this patient. And you have a very interesting systematic review and meta-analysis that was published 2 years ago. And you see that around 23% of patients can achieve pregnancy at the maximum age of 40. So I think it's not so bad in this population, but obviously the younger the patient try to conceive, the higher the chances that they obtain a live birth. And when you consider the mode of conception in these patients, well, you see that in around 1/3 of cases it's spontaneous, and in 2/3 of cases patients obtain pregnancies through fertility treatments. An important point is when you plan conservative treatment is to correctly assess the initial disease, and you have to perform an MRI or transvaginal ultrasound in a specialized center. That's a first point, because it will help you determine how deep is the myometrial invasion. And you can also perform a CT scan if you have any doubt regarding lymph node involvement in this patient or distant metastasis. So initial treatment relies on two things, hormonal treatment and hysteroscopic resection. And as you can see on this slide, the association of these two treatments provide with the best outcome regarding the rate of complete responses, the rate of recurrences, and the chances of pregnancy. It's very important to tell also that no peritoneal metastasis or infertility through the development of synertia has been reported in this specific population. So that's what the European guideline clearly states, that the combined approach is the most effective fertility-sparing treatment. I'm not going to tell you a lot today about the hormonal treatment, but basically it's progestative, either through oral progestative or intrauterine device. Another interesting point is that for a long time we performed diagnostic laparoscopy in these populations that were suitable for conservative treatment. Today we know that there is no use of this laparoscopy in this population. It's important to inform patients that when a conservative treatment is performed, the chances of getting pregnant are higher as soon as the complete response is achieved, and patients should aim to conceive as soon as possible in this population. That's really important, because we also have to discuss with them the timing of radical treatment, non-conservative treatment. So an hysterectomy is proposed either if there is disease progression for stage or for a grade, if the fertility prognostic is unfavorable after conservative treatment, or obviously if there is disease recurrence. And the chances of complete response are pretty high, as you can see in this study that was published, because you achieve almost 80% of complete response, which is quite high. And another interesting point is that patients that will lose weight when there is a diagnostic of endometrial cancer, they have decreased risk of recurrence, increased chances also to obtain pregnancy. So I think we should clearly inform patients about the benefit of reducing their weight in this population. And also an important point is to inform them that hysterectomy remains the rule once the pregnancy project is over. So usually we wait for at least the patient obtain one live birth, but it can sometimes be discussed to wait for a second pregnancy with a close monitoring. It's important to say that pregnancy with a high dose of progesterone during the pregnancy is a protective factor for the risk of recurrences. And another question, but I think Professor Chabbert-Buffet is maybe going to discuss this matter, is the question to conserve or not the ovaries during radical treatment for early stage patient, well, stage 1A and A2, under 45, yes, it can be conserved, but salpingectomy of both sides is recommended, or it can be discussed according to family history, but for other patients, usually ovaries should be removed during the treatment. Let's now move to cervical cancer. So there is really clear guidelines published by the ESGO on this matter. Just to remind you the actual classification of the cervical tumors. So basically, patients suitable for conservative treatment are those, of course, at the age of conceiving, that have tumor inferior strictly to 2 centimeters. And that seek for parenthood. We have to inform patient due to this specific location about the obstetric risk that might occur once the conservatory treatment is done. And once the patient of the treatment abandoned the fertility therapy, if positive resection margin or lymph node involvement is diagnosed, because as we're going to see just a slide following this one, the treatment relies on both excision of the tumor, complete excision of the tumor, and also lymph node assessment through sentinel lymph node and pelvic lymph node complete removal. And in patient with positive lymph node, obviously the fertility sparing treatment cannot be pursued. So it's important to achieve a free margin and preservation of the upper part of the cervix. So different kind of procedures are available for clinicians, and the next slide is going to summarize that pretty well. So conization, simple trachytectomy or radical trachytectomy through vaginal approach, or sometimes through abdominal approach. And the smaller size the tumor, the simpler the treatment gets. So for stage 1A, 1-2, simple conization is usually enough. For stage 1B, 1, so tumor strictly inferior to 2 centimeters, you have to assess for involvement of pelvic lymph node. And of course, no fertility preservation can be proposed for patients with tumors superior or equal to 2 centimeters, which is the stage 1B2. When pregnancy is achieved, you have to consider the pregnancy as a high risk because, well, you removed pretty much part of the cervix. And as it's not like we said before for endometrial cancer, routine hysterectomy is not mandatory in this population. So it's quite a big difference with a patient with endometrial cancer. And to finish, patient with ovarian tumors. So just to remind you, the FIGO classification of the ovarian tumors, it is a FIGO classification for invasive tumors, but it can sometimes be applied for patients with borderline and implants in the peritoneum. And you know that the whole classification of the ovarian tumor can be really complex with a lot of different types, and we are going to try to see quickly how each histological type can be considered. So the recommendation states that the fertility sparing surgery is an option in patients with early stage ovarian carcinoma. It is a consensus conference, so basically it relies on 39 patients that stated that it's a good option, but it's hardly based on a lot of literature in most cases, and it should always be discussed during a multidisciplinary session, of course. Patients that have the young patients that have ovarian carcinoma should always be managed in oncofertility clinic, and that's a really important point. And minimally invasive surgery is always an acceptable approach in this patient to wish to preserve that fertility as soon as it possible, meaning as complete removal of the lesion is feasible without tumor rupture. So when you consider stromal tumor and sex cord, so the main goal is to avoid tumor rupture. You have to plan for complete secondary staging if it was not performed initially. And patients with stage 1B, 1A, 1B, sorry, to stage 1C, wishing to preserve fertility or hormonal function, they can be elected for unilateral annexectomy, peritoneal cytology, endouterine curettage, complete omentectomy, and multiple biopsy with no gesture required on lymph node in this specific histological type. For patients with non-digermatomous tumor, unilateral annexectomy or bilateral, if the tumor, of course, is bilateral, is an acceptable approach. For patients with digerminatomous tumors, stage 1A to 1C3, wishing to preserve fertility or hormonal function, well, you can do a complete staging with unilateral annexectomy and a complete omentectomy and multiple biopsy with no gesture on lymph node. And you can also discuss this for patients stage 2 to 4 wishing to preserve fertility, but it will imply a longer and more complex surgery. In patients with cancerization of mature teratoma, if the tumor is strictly limited to the ovary, unilateral annexectomy, omentectomy, and peritoneal biopsy is feasible. And you have to add an appendicectomy if it's a mucinous carcinoid. And if malignancy is diagnosed in non-carcinomatoid tumor, you have to discuss a complete lymph node removal, pelvic and para-aortic. And in low-grade serous adenocarcinoma, in patients with early stage, always, that's the only population suitable for this approach. You have to perform an unilateral or bilateral annexectomy, depending on the size of the tumor, complete peritoneal stadification, and complete pelvic and para-aortic lymph node removal. I think the most frequent forms of ovarian tumor in young patients remain the borderline tumors. So our French college, the CNGOF, has issued recommendations for patients desiring to preserve fertility, which they should benefit if there is no argument to recommend a type of ovarian surgery, cystectomy or oophorectomy unilateral, a complete peritoneal stadification with peritoneal washing, exploration and multiple biopsy, omentectomy and appendicectomy, especially in cases of mucinous tumors. And eventually you have to say that some types of tumor are not eligible for conservative surgery. It's important to keep in mind that uterine and ovarian tumor carcinosarcoma, for example, are not suitable. And sometimes you can discuss conservative surgery in patients with clear cell, but again, that should remain the exception. So to conclude, there is a question on how to assess fertility chances in the context of a recently diagnosed malignancy, and it's always a really intense, sometimes discussion in the multidisciplinary committee. The European guidelines are here to support physicians, but again, they cannot replace case-by-case evaluation and patient expectation. The multidisciplinary team session should encompass expert reviewing of both the imaging and the pathological specimen. It's important for the physician to feel confident on how to inform the patient and the couple in their parenthood project. And another point is long-term follow-up, and more data is required to improve patient selection suitable for conservative treatment. Well, thank you very much, and I hope it was clear enough.
Excellent talk, precise, and the time was on spot. Before moving to our next speaker, Professor Nathalie Chabbert-Buffet, I'd like to introduce myself. I forgot that because we were a couple of minutes late. I joined the webinar from Istanbul. I currently work as a full professor of obstetrics and gynecology at the Medical School of Marmara University. My field of interest and expertise are similar. I'm a reproductive medicine and surgery person, mainly focused on menopause and menstrual disorders, medical and surgical management of endometriosis, and of course, minimally invasive surgery. I am a member of a couple of international associations. I currently am one of the co-chairs of the Council of Affiliated Menopause Societies in IMS, International Menopause Society. I am on the editorial board of a couple of journals, and I currently have more than 100 peer-reviewed publications and a couple of chapters in Turkish textbooks. And thank you for the opportunity, Professor Chabbert-Buffet. And now we will move to your presentation, which is hormonal treatments after pelvic tumors, contraceptive and substitutive hormonal treatments. The screen is yours.
Thank you very much. We are both in the same room, so we need to turn off the microphone of the other one. So thank you very much for inviting us in this symposium. So the topic is hormonal treatment. These are my links with the pharmaceutical industry, since I'm going to talk about hormones. And so why do we want to wonder about these hormones after pelvic cancer? Because things are moving a little bit. Incidence of cancer is going higher. The age at diagnosis is going lower. The prognosis is improving. And the quality of life during and after treatment is a real topic now in the care of these patients. So I just wanted to update maybe your ideas on the cumulative incidence or the cumulative risk of the different tumors we're going to discuss now. So the cervix cancer, it ranges between 0.4 to 2.7% on over life, depending on the country you live in. So maybe you can try to find yours in this map. Not very easy, I agree with that. So this is cervix cancer. This is corpus uteri cancer, 1.5 to 3.8. And this is ovarian cancer, all mixed, all kinds of cancer, of course, 0.9 to 2.3, depending on countries again. So this is not a very high cumulative risk as compared, for example, to breast cancer, which is here. But you can see that the corpus uteri is the fourth one on the list, of course. And so the incidence globally is about 1.8 million women who are diagnosed with gynecologic tumors every year, malignant tumors. And the treatments that we can offer, which are surgery with bilateral oophorectomy, pelvic radiation, or chemotherapy, can of course induce premature ovarian insufficiency or early menopause. So the evolution of cancer prognosis, as I said, this is the example for the endometrium, for example. In early stages, the prevalence increases regularly, and the high level of tumor-free survival is very interesting. So you can see here the cumulative prevalence for stage 1 is 40% if diagnosed before 50 and 40% before 60. And the recurrence-free survival at 18 years is close to 100%, 97 before 50 and 95 before 60. So one of the questions is, can we preserve ovarian function? So we can. So this is a review I'm going to be working a lot with by Hickey and et al. Published in the Lancet very recently. So the conclusion of this paper is you can consider preservation of the ovary in premenopausal women with a cervical cancer stage 1 or 2A HPV positive. It can be squamous or adenocarcinoma, no difference. Then with these patients undergoing radical hysterectomy, you can preserve the ovaries. You can preserve the ovaries as well in endometrial cancer stage 1. We've already discussed that with a low grade 1 or maybe 2, but no more, without a genetic predisposition such as a Lynch or a P53 mutation. But we have to know that information about the molecular subtyping of these cancers are still not very frequently done and are not included in the data we have on fertility preservation. So we have to keep tuned on this information for the future. And then ovarian cancer, stage 1A, low grade, we can save the contralateral ovary. But we really need to explain to the patients that the risk of recurrence on this ovary we're going to leave into the abdomen is quite high, 6 to 13% risk. We can also preserve the ovary with the germ cell tumors. If in some situation we can propose a transposition of one of the ovaries, which will provide hormonal function in the future, but is not really effective for fertility in the future. And this is in young patients before 40, and this could be done for cervical cancer locally advanced if primary chemo radiation is planned. So we want to save at least one ovary. And cancer requiring pelvic radiation, whatever gynecologic or not. And we can also consider intraoperative transposition in women with cervical cancer if radical hysterectomy is abandoned due to the positive node or if adjuvant radiation is likely. So the answer to this question, hormonal treatment after pelvic cancer, if you could not say the ovaries, is a complex answer because the level of evidence that we're going to see is not very good. There are multiple forms of cancer, especially in the ovary, and also in the endometrium, if we consider the molecular classification. We still do not know anything about that in the reality. And we have to consider hormone-dependent tumors or not in the reflection about that. So how about the level of evidence? You can see here this recapitulation by Hickey et al. And you see the level is either very low or moderate. Nothing is just, okay. So depending on the type of tumors, and you have these levels of evidence that are very low. So the conclusion about the treatment is, well, you should maybe avoid, or maybe you can think about it, but you, of course, are going to have to discuss a case by case, as already stated by my colleague in the multidisciplinary team meeting. And you can see that, for example, in the cervical cancer, one small retrospective study is 120 patients found no effects on cancer outcomes. So, and everything is a little bit like that in this topic. For example, about the endometrial cancer, I was in charge of analyzing using the PICO methodology for the national recommendation this year, the impact on the risk of recurrence in a woman who has a low or intermediate risk of endometrial cancer with lower intermediate risk of recurrence. So I've been searching the whole library, so 9 cohort or case control studies and 4 meta-analyses and 1 single randomized control trial, which was not completed because the WHI was published at that time, and so they could not finish the inclusions. And in the meta-analysis, everybody says the studies are heterogeneous with low quality level. So we can conclude no increase in recurrence risk or specific mortality in users of MHT if the tumor is endometrioid type. Other types are underrepresented, so we don't know. Stage 1 or 2, if you want a more higher stage, you have only 8 patients in one study and 2 patients in another one. So you cannot really say anything. And in the randomized control study, which was not terminated again, the risk of recurrence was 1.27, which was not significant. So based on that, you say you may offer MHT to a woman with a limited endometrial cancer. So you can see this is really, we need to inform the patients about the low level of evidence we have to think about all of this. So this is the paper I really recommend you to read now. Probably some of you know Dr. Hickey, Dr. Partridge, which are very well-known physicians, and they know the field very well. And this is a synthesis of their paper I'm going to describe for the different types of cancer. So for cervical cancer, the HPV-related cancers can have MHT. It can be discussed with the patients and with the colleagues, but it's okay. You can do that, including adenocarcinoma. If they are non-HPV related, then be careful, especially in some specific subtypes like gastric subtype. For the uterine cancer, carcinoma can have MHT, as I just said, if there are limited stage endometrioid. And in this conclusion here, they say serous and carcinosarcoma. I could not reach the same conclusion when I did the research myself. Sarcoma can be estrogen sensitive, so do not imagine to give MHT, especially in leiomyosarcoma, or maybe in some very specific, very young women sometimes, high-grade endometrial stromal sarcoma as well. And the low-grade endometrial sarcoma and adenocarcinoma should not receive MHT. As far as ovarian cancer is concerned, it will also depend on histological subtype. So you can discuss MHT for high-grade tumors, serous, endometrioid, mucinous, clear cell, borderline, if you have fully resected the tumor and there are no invasive implants, and germ cell tumors. On the contrary, you should not propose MHT to low-grade serous, granulosa cell tumors, and sex-cord stromal tumors. So the risk-benefit balance, of course, has to be discussed depending on the patient's age, the interval since cancer treatment, the impact on quality of life of the symptoms. Her vascular and bone status may be included, and the multidisciplinary team meeting, as we said, including imaging and pathology analysis and discussion with the peers, is really at the center of the discussion. Are there alternatives to the treatment? We know a lot of them, which are some treatments, some different approaches to the symptoms of menopause. And so they are not all effective on the different problems of the patients. Maybe you can go to this reference by Vicky and see that more in depth. And we cannot offer a satisfactory solution which will replace hormone therapy for all the problems of these postmenopausal women, unfortunately, but we can help with all these strategies if we cannot offer hormones. So that was for hormonal menopause treatment. What about hormonal contraception? It is not a very frequent question. In France, we tried to answer the questions in 2018. So we ended with a Delphi consensus. You know what this is. You have experts. They say, well, I think we should do that. And then they share the idea with their colleagues, and they share it once and twice and 3 times. And at the end, if everyone is okay, then we get out with that conclusion. So that's what we did in that year, 2018. So we said, ovarian cancer, you cannot use the combined pill in case of granulosa cell. You should avoid hormonal contraceptives in low-grade tumors. It's just like for MHT. And in all other cases, then you could use hormonal contraceptives, except for the adult granulosa cells, which can use only progestins. Cervix cancer is very easy. It's okay for whatever the type of cancer. And endometrial cancer is very specific, and Professor Dabi has discussed that before. It's just for these very early stages, low-grade women who absolutely want to preserve their uterus for pregnancy. So we treat them with progestins, which will do the contraception also until they have their baby, and then they can have hysterectomy. So this is very limited experience, limited data in the literature, and expert consensus. And the same has been stated recently by the Society of Family Planning with their clinical recommendation. Their conclusions are the same as those we had, and the level of evidence was mostly intermediate to low as well. So as a conclusion, the answer to the question, can I have hormones, is not always no. We can stop and think a little bit, but we may inform the patients on limited level of evidence and share the discussion with them, the patients, as well as with our colleagues. We maybe should try alternatives first in many cases, especially in complex cases. The multidisciplinary meeting is really your best friend, as I said before. And the hormonal treatment should be offered only to women with symptoms, hot flushes, and so on. If we decide to give her hormones and she has no uterus, you know, of course, that estrogens only are sufficient. So these are the main references you can take a look at if you want to learn more. And I thank you very much for your attention.
Thank you.
Thank
you. Excellent, precise.
Just cannot hear you.
Oh, sorry. Can you hear me now? No. My mic is on now.
No, we still can't hear you. I'm sorry.
I don't know what happened because it was okay in the first place.
What happened? My audio
So
is.
maybe you can ask the audience if they have any questions.
Yeah.
Yeah.
Now you can hear me, right? Okay. Well, thank you, both of you. Excellent talks, just spot on time. So we have time for discussions. I've got a couple of questions to Professor Yohann. Some you answered during your talk. Some maybe we need to emphasize more. I will go with this one. How do you counsel patients regarding recurrence risk, follow-up intensity, and optimal timing of pregnancy after fertility sparing surgery? Your mic is off.
Yeah, well, it's a good question. I think a lot of the information you give depends on the disease and the age of the patient. Once you establish that there is favorable chances of the patient indeed getting pregnant, in case of endometrial cancer, you should tell them about the first step, which is hysteroscopic complete removal of the disease as well as hormonal treatments. And at that time, you have to establish whether the patient do present complete response or not, because that's your first stop. If the patient does not have complete response, you can after 6 months usually, you can still discuss for 3 to 6 months supplementary to try to achieve complete response. But if there is no complete response, you have to maybe change strategy and counsel patient about the risk of disease progression if not achieving if not performing a non-conservative treatment. But again, as Professor Chabbert said, it's your best friend is a multidisciplinary committee. So I think it's an important point to tell them in endometrial cancer. In cervical cancer, it's a little bit different because you can achieve complete excision of the disease and performing the complete hysterectomy is not mandatory if you are certain that the complete disease is removed. So I think the discussion with the patient is a little bit different, but in endometrial cancer, it's really important to tell them about this.
Thank you. A second question would be, how are we planning to improve patients' selection for benefiting of the fertility sparing treatment?
Well, I think there is two sides in this question. First is how we correctly identify the patients that have really good chances of getting pregnant, and we all know in our European countries we're already not doing the same for fertility treatments, or so obviously that's a big difference we have across our countries. In France, for example, you cannot access fertility treatment if you're over 43 to get oocytes retrieval. So that's an important point to discuss. So I say my first point is to discuss what are the true chances of the patient to achieve pregnancy. And the second point is, remind me the question again, I'm sorry.
Improve patient selection for benefiting of the fertility sparing treatment. So which patients would benefit the most?
So first is to correctly identify, and this is through improving the parameters we use to define the chances of getting pregnant. And I think research may be the most important. We know even if we have different strategies across our countries, that maybe pulling some data and conducting large studies, large cohort studies with important follow-up is a good approach because we are going to need a lot of data to correctly assess these patient chances to get pregnant, and maybe the artificial intelligence through like digital twins can help. I don't know if we're going into this discussion, but it can offer an alternative to select these patients.
Artificial intelligence has some value, but not as high as it is taught. It's not there yet. Thank you. Question for Professor Chabbert-Buffet. The question is, can menopausal hormonal treatment affect gut microbiota in patients with pelvic cancer? And this could be a risk factor of cancer, apart from the direct effect of on the receptors in pelvis.
Well, we know that hormones can have impact on the microbiota, but unfortunately, we do not have data on we know hormones can modify, but we don't know if the modification will increase the risk of cancer linked to hormones. So there are data on microbiota and cancer, data on hormones and microbiota, but the link between everyone is not done. And as I said, there are so many different kinds of cancer that the answer cannot be unique, of course. So it's much more complicated. I'm sorry.
Oh, the data is not there yet. We have another question. I think this is for Yohann. How should response to treatment be evaluated in early endometrial cancer managed with a fertility-sparing approach after hysteroscopic resection and progestin therapy? And how is a complete response defined?
Okay, so maybe I've been fast in this part of my presentation, but when you initiate therapy, you always have to perform a new evaluation through controlled hysteroscopy at 6 months. And in most cases, so at 3 months first and then at 6 months. And in most cases at 6 months, most patients have a complete response, but you have to perform a systematic biopsy when you perform the hysteroscopy to make sure at the pathological level that you have a complete response. And then if you have complete response, you can discuss with the patient to initiate their pregnancy project.
What is the definition of complete response?
It's both macroscopic.
Pathological definition, is it? Yes,
it's pathological, obviously, through the hysteroscopy, and then with a specimen harvested from the controlled hysteroscopy.
Okay. Another question, again, to you, Yohann. Which selection criteria are essential before offering fertility-sparing surgery in pelvic tumors? Tumor type, stage, imaging features. So, I mean, you went over those, but what are the most, important parts? The stage or the imaging feature or the...
I think it's hard to answer this one, but because as you saw, the patient suitable are already pretty really subpopulation, really clearly defined. So it's hard to find across this tiny population that might benefit from this conservative treatment, which parameters, because for example, in endometrial cancer, the only patients eligible are those with stage 1A, grade 1 tumors, in exceptional cases, grade 2, but we already talking about really a subpopulation, really narrow. So I'm not able to tell you which of the criteria. And
just
obviously,
follow the guidelines, probably.
The tumor type is the tumor parameter, sorry, is important, but the patient parameters are also really important. and you always have to discuss whether the patient already have children, whether they were trying to conceive, because in a lot of cases you diagnose endometrial cancer in the time the patient and try to start fertility treatments. And during the diagnostic workups that they are doing in the fertility clinic, they diagnose endometrial cancer. So really there's a lot of parameters to be included in your reflection and to share with the patient to assess whether it's a good choice or a pretty bad one to go through conservative treatment.
Let me ask you a question. What about those genetic ovarian breast variants? You know, there are young girls who are either recently married or not conceived yet. How is your approach in terms of fertility sparing options?
Well, I mean, the variants that we know the signification of, or the pathological variants, you mean?
Like we see patients who have breast cancer and they are genetically tested and they have the variant. So most likely their ovaries has the risk, increased risk. So they would need risk reduction surgery at a certain point. How is your approach as fertility sparing or risk reducing approach to these young ladies?
Well, maybe this is a question for Professor Chabbert-Buffet, because she has a dedicated consultation to the high-risk patients. I think she'll be more able to answer you this question.
It will be our privilege.
Thank you. So the patient has breast cancer. She's at risk for ovarian cancer. So she's young, she's before 40, let's say. So we will offer oocyte cryopreservation for the future. And the younger she is, the better. But because she has breast cancer, I'm sorry, I have to say that. And then the problem with the ovarian tissue cryopreservation, because this you would use by grafting it back into the abdomen or the pelvis or the ovary. And this, we do not know very well what happens with this tissue that has been harvested, frozen, then used later on, and what is going to happen. So you know maybe that the team in Belgium has done that once. So they grafted and the woman had a baby and then they took off the ovary 1 year later. So nothing happened. So we can imagine that kind of approaches, but the best would be to freeze oocytes, I think. Although it does not always work, as we all know. But and maybe encourage her to have a baby as soon as the oncologist is okay with that, too, before we can remove the ovaries. It's not easy.
Another question maybe related with this. Let's say that this time it's a young girl, 20s, 30s, and she has ovarian cancer, early stage, and has the genetic variant. So she will need maybe breast lumpectomy in the future. The approach would be the same as Yohann already mentioned, right? For fertility sparing, similar, and the rest will kind of work itself for the breast, at least, if there is a genetic tendency for breast cancer.
Yes. We have a dedicated pathway, for example, in our hospital. And once they are diagnosed with this kind of mutation, well, they are managed for the cancer they have, and then there is a specific follow-up for example, breast screening.
Okay.
then we can offer a risk-reducing surgery for the breast as well, if she wants to, which is not very frequent in France. We're not very good at that. But if not, then we can have screening with MRI and mammography every year. And this is well, quite efficient, let's say.
Any questions from our audience? Okay, there is this question. Is oocyte cryopreservation in all types of pelvic tumors possible?
So you can freeze oocytes only if you are at a very early stage, after treatment, after surgical treatment, and then you go in just after the surgery and before the rest if needed. If the per-operative consultations have not shown any risk on the other ovary, of course. So and after getting the results of the pathology after the first surgery. So if everything is clear, then you rush to freeze some oocytes, and then she can go on with the rest of the treatment if needed.
Thank you. So I'm waiting for other questions. We have time, even though we started a little bit late, but thanks to the excellent talks, we have quite time for discussion. Do any of you want to add more or ask, make any comments on this topic?
No, I would really recommend reading the paper in the Lancet. As I said, it's a very nice paper.
Yes.
So it gives you all the information in detail that you need, and as you see, the graphic part of the paper is excellent as well. So the Lancet is a reference, by the way. So you can really rely on that, and really, I think the main message is, in fact, there is a type of cancer and so on, extension and blah blah blah. But the woman and maybe the couple in front of you is also something really central to the discussion, and we cannot just say, well, no, we're not going to do that because we don't want to, and the couple is just destroyed. So we have to have in the multidisciplinary team psychologists also, and support of all kinds for the patients and the couples. It's just not a woman very often. It's also a couple. So I think the team is a very large team.
Yeah, it has to be multidisciplinary, and the data is not that robust. As I followed your slides, there is something there, but the couple, as you mentioned, they want the most relevant information for their future, for their family's future, and unfortunately, it's not out there yet. So as I was telling Yohann regarding the artificial intelligence, still it's all about data. So if you don't have valid data with good sample size, even artificial intelligence will not be helpful. So,
obviously.
That's something to just clear in the minds of the couples that you and we see, and try to share them the available, valid, correct guidelines, the regulations, what we have right now.
And sometimes you don't have the answer. I mean, there's a lot of situation where there is no clear answer, and that's the whole value of the discussion between us, between experts, between the different specialties. And that's something that really matters in these specific cases.
So, some of the audience are thanking you for the excellent presentations. let me just share it with you. And I really enjoyed, because recently I gave a talk in our in-house meeting in the hospital regarding fertility preservation. Since this month is the cervical cancer awareness month, the nursing staff in my hospital, they asked me to give a talk to the medical staff there. And it's so nice to meet you and hear your expert opinion and your practices in the field. And thank you again for sharing these with the audience tonight. And thanks to European Society of Gynecology for organizing this webinar to reach out to those who are interested on this topic. And since we have no other questions, I wish you all the best. And in some parts of the world, it's good morning. And here in Istanbul, it's good night. I know it's in France. It will be good afternoon. So hope to see you at another scientific meeting, and wish you well in your clinical practices.
Thank you. Thank you. Have a good day.
Thank you. Thank you.
Good evening.
Good evening. Good evening.